Welcome to Better Sex, where you get the information and inspiration to create and enjoy your best possible sex life. Join your host, sex therapist Jessa Zimmerman, as she brings you expert guests, helpful tips, knowledge, and strategies to improve your intimate relationships. And now, your host, Jessa Zimmerman.
Hey, welcome back to the Better Sex Podcast. This is Jessa, and I am thrilled you're here. I am always honored that you choose to spend some of your time with me, and my intention is to make it worth your while, make it interesting, and especially make it helpful, make it relevant. You know, even if it's not relevant for you right now, that this is sort of in your pocket when you need it, or it's available for information or resource for someone you know and love, right? That's the goal here, that I can be helpful with this time that we spend. And in that vein, I'm always looking for topics that are useful and interesting. There's so much to cover when we talk about sex, right? We talk about the kinds of struggles that people have with sex. And today's episode, I think, is going to be really, really powerful. I'm even guessing this may be one of my most listened to ones, but we'll see. Time will tell. We're going to be talking about testosterone today. And what happened is, I know the guest today, Dr. Serena McKenzie, I have known actually for a long time here in Seattle. And I happened to see an article that she wrote, a blog post about sort of the risks of testosterone supplementation in men that don't need it, or men who are not properly advised about it, and how it basically undercuts your ability to make your own, which I didn't know before reading that. So anyway, I decided to have her on the show. And so she's going to share all about, what is testosterone? What does it do? Why is it important? How do we know if it's really low? And even if it's low, how do we know that it warrants supplementation? Because it really could be a symptom of many other things to have sort of lower testosterone production. And then what are some of your options, and how does treatment work, and how do you evaluate this? And especially, how do you find a provider who's going to be really an appropriate person to consult about this, instead of just going into one of these clinics that you spend 5 minutes, they give you a bunch of treatment without much screening or testing appropriate. So anyway, I think it's going to be crucial, and I hope you get a lot out of it. The Better Sex Podcast is brought to you by the Sex Without Stress online course. It's a course for couples to escape the cycle of disappointment, avoidance, and pressure in your sex life. So if you're in a pretty good relationship, there's a lot of love and goodwill, but sex is your struggle, this could be for you. You work in the privacy of your own home and at your own pace to create a sex life you can both look forward to. If you want to learn more, go to sexwithoutstress.com/program. Great. Serena, thank you so much for taking the time to do this today.
Awesome. You're welcome. Thanks for having me.
I think this is a really, really important topic. I'm so excited. I saw your article, linked to your blog post, I think, which was what made me think I have to talk to you on the podcast about this.
Great.
So why don't you start off just, what is testosterone? I know it's a word probably people have heard, but exactly What is it? What does it do? Why is it important? And I don't know if you want to say a little bit about how it might be different in men and women too.
Sure. So testosterone is a hormone that men produce primarily in their testicle tissue. Women produce testosterone in their ovaries and in their adrenal glands, but it's a more primary hormone for men. So it drives puberty. It drives an enormous long list of bone density, growth, sexual function, cognitive function. So it's a really critical hormone for men, and it starts production at puberty, which is usually around 12 to 13 in males. And it's something that has relevance for medical conditions over a lifetime. And so it increases exponentially through puberty and kind of peaks around age 30 and then starts to decline as men age. And so testosterone medically has a lot of relevance when we're talking about conditions that cause deficiency of testosterone production. So that's normally what we're talking about, is the different types of medical conditions that can either reduce the production of testosterone or cause the inability for a man to produce it at all.
Okay. And then it sounds like it's also important if somebody has lowered testosterone, there's also medical implications of that, right? Like that might cause other things or
That's right.
contribute to other
Exactly.
things.
Yeah, men have a low testosterone condition, and there's a lot of different kinds. If they don't have that treated and evaluated, for example, one of the most significant risks is bone density loss as they get older. So osteoporosis can develop if a man has a untreated or undiagnosed testosterone or testicular dysfunction.
Okay. So what are some of the causes? You're saying there's sort of a lot of different conditions that can drive lower testosterone?
Yeah, there are. I mean, historically, endocrinology had defined some really strict kind of definitions of what we call primary or secondary testicular hypogonadism, so to speak. And what that means is that there is a condition where the brain, the pituitary gland in the brain, does not produce enough stimulating hormones for the testicles to produce testosterone. And then we also look at a very classic condition called testicular failure, where the testicle tissue itself is not able to produce hormones. So that's historically what our primary endocrinology disorders were looked at. Over the past 10 to 15 years, we've had this huge exponential increase in conversation around low T or low testosterone. And that is a conversation regarding how men age and what a normal testosterone level is. And it's created a lot of controversy and sparked a lot of conversation in the medical field as to what a low T condition legitimately is or is not, because there are a lot of controversial approaches suggesting that a man who does not have pituitary dysfunction or does not have testicular failure, who has all of those functions intact but has like a lower perhaps level versus a higher level, is that a medical condition or is it not? So that's where the area of controversy gets inboard quite a bit, because there's a lot of men in the United States, millions and millions of men, who are utilizing testosterone therapy potentially quite inappropriately because they do not have one of these clear-cut medical diagnoses. Because even in medical societies, we're still debating quite a bit as to what level of testosterone is considered medically low.
Yeah. Okay. So if the pituitary gland is not sending out the signals, or the testicles are not making testosterone, that's an organic condition that needs treatment, right? But
exactly.
But then if you're just if all that's working, you're just measuring levels somehow. That's where it's controversial.
That's where it starts to get controversial. Yeah.
All right. And first, how common are issues organically like that? Like, is this a common kind of thing that somebody's pituitary gland isn't sending the signals, or their testicles aren't making it? No.
I would say I don't have any statistics prepared for you, but statistically, I think it's very safe to say that a very, very small percentage of men in the United States currently receiving testosterone therapy actually have an organic hypogonadism diagnosis. And that's one of the reasons why it's very controversial, because when we're looking at the diagnosis medically of hypogonadism, there are very specific criteria that generally we align with. We have urological societies, endocrine societies, sexual medicine societies, and they are all a little bit different. And so that also brews confusion because we don't have a general consensus. And so on the whole, though, I think we have certain medical criteria. We're close. We have certain medical criteria in terms of when that testosterone level should be drawn. It should be drawn on several occasions because testosterone levels have kind of a circadian rhythm and they fluctuate throughout the day. So if we take a testosterone level, for example, medically in the afternoon or evening, we really don't consider that accurate. It needs to be drawn fasting between 8 and 10 in the morning. These sorts of things. And so what I think the other controversy and concern is that a lot of physicians either are not educated on these guidelines or choose to ignore them and will make a diagnosis that medical guidelines don't agree with and consider that low testosterone. And so the concern is that there are a lot of lifestyle reasons why men may have suboptimal testosterone production, meaning obesity, diabetes, insomnia, sleep apnea, sedentary lifestyle, smoking, a lot of things where guys just aren't taking care of themselves and they have sluggish testosterone production as a consequence of poor self-care. And so then the question is like, well, what's causing these lower testosterone levels? And most of the time, it's not an organic dysfunction of testicular or pituitary tissue. It is, frankly, a guy just not taking care of himself. And so those things are also really critical, especially when we're talking about sexual health and testosterone, which is where it comes up a lot in my practice as a sexual medicine specialist. We're trying to understand, well, what's causing a man who has erectile issues or low libido? Is it a testosterone production? Or then it goes into this whole other wheelhouse of oftentimes men struggling with sexual dysfunction also have depression, are overweight, have sleep issues, are not taking good care of themselves, are over indulging in alcohol, for example, which is another key factor that can change testosterone production. So the bigger conversation then becomes, is testosterone really the issue at all? Or is it simply a reflection of a compilation of poor self-care and other comorbid conditions that are causing poor self-care? And that's usually what I see in my practice, is that we may see a low normal testosterone, but then that shouldn't be the end of the conversation. And what's also really critical to know is that when we give a man testosterone, we turn off his own testicular production. So what that means is that if you're a young guy in your 20s or 30s and you're not properly informed about the benefits or risks of testosterone, and even if it's not particularly an appropriate prescription for that man, he could become infertile and not be able to have children later on in life.
Wow.
So that matters a lot. What I'm trying to say is that there are really complicated benefits and risks to testosterone therapy, and it's important to work with a clinician who can walk a man through all those. Because if a young man genuinely has met these criteria for medically low testosterone, as I said earlier, we certainly want to address that and treat that patient. There are treatments that are more appropriate for men who are younger that help stimulate the testicles to make more of their own testosterone, and that preserves fertility. And so those are the better choices for men who genuinely meet medical criteria and are younger and are interested in a pregnancy later on in their life. And so that's another area where it gets really sticky, because we have a lot of clinicians or men who are finding testosterone online or places they shouldn't be getting it. It's a controlled substance. It's not supposed to be readily available, but it super is. And so, if guys are abusing testosterone, first of all, what they typically find is that it doesn't enhance their sexual function the way that they're kind of expecting.
Because they're looking for a magic pill, right?
Yeah. They're looking for that magic pill. And, there are a fair amount of clinicians who kind of tout it that way because they make a lot of money off of selling it. So it's just kind of trying to sort through the weeds of we want men to be appropriately diagnosed and treated, but we also really want to try to stifle out the ones who have other issues that are causing their symptoms. Because the other confusing point is that low testosterone creates a lot of symptoms that are relatively non-specific, meaning a guy will complain, I don't have a lot of energy, I'm kind of tired, I feel a little depressed, my erections maybe are lackluster, I don't have the same sexual drive. And that also can be suggestive of a long list of other things.
Exactly.
And so the other piece that's important for men to know is that there are specific symptoms or physical findings, such as shrinkage of the size of a testicle. I'm going to just show you here real quickly. Maybe you can see this or not, but I'm showing you one of the medical tools that an endocrinologist uses is measuring the volume of testicular size.
Okay.
And so that's something that's specific to men who have a medical testosterone deficiency. The testicles will shrink sometimes to the size of marbles. Frankly, they can become very, very small because they're atrophic. They're not functioning properly. The other symptom that can be strongly suggestive of testosterone specifically is if non-sexual erections are diminished, meaning if men start losing that spontaneous erection in the morning, and that's consistent, that goes away. That's another symptom that we tend to correlate to low testosterone. But the other problem is that there's vascular disease or pituitary dysfunction can also cause some of these changes in erections. So it takes a lot of time to kind of sort this out, and it's pretty easy to diagnose testosterone appropriately by a doctor who knows how to do it. So that's the good news, but sometimes it's a little confusing in the marketplace as to who those clinicians really are.
Okay, so let me take apart. You covered a lot.
I know. I'm sorry.
No, it's okay. That's okay. There's just so much to say about this, but I want to slow it down a little bit. So in terms of testing for low testosterone,
Yes.
There's a protocol for that. What do we know about the levels men should have and at different ages? Like, is that even,
Yeah.
is that
Sussed out.
known? Yeah. Is that sussed out that
Yeah.
what levels
Yeah.
guys should have? If they're tested, fasted between 8 and 10 a.m., like at the appropriate
Yes.
time, do we know
Yeah.
at different ages?
Generally speaking, and this is one of the areas where we have a lot of discussion in medicine, below 300 or 350, there's a specific marker on labs, is what we're looking for, and that has to be reproduced. Because what I can also tell you is that we can draw a man's testosterone level on day 1, and then on day 5, it's a completely different reading. And so that reproducible low testosterone is important, and a lot of clinicians miss that step. They will do one test and they'll say, oh, it's under 350, or they'll even say it's at 500, but we think that's low, so we're going to treat you anyway. So there's a lot of variations, and men presenting for healthcare are going to be confused because there's not always a unanimous approach.
Okay, so multiple reproducible results. And then is it under 350-ish for men that are 30 and men that are 65?
Yes, generally. And yes, that could be, of course, one of the areas where we kind of discuss in medicine. We don't have set levels. We have like a range. And so we have a range, and then we match that to symptoms. And so if we have a man who has, and I mean, I've done this for years and years. I can tell you there's plenty of men who have testosterone at 350 and are healthy as a whole horse and they feel fine. And I have plenty of men who have testosterone at 900 and swear inside out and backwards that it's low because they have trouble with their erections or they have depression or fatigue, and we'll do it over and over. I have several gentlemen who get obsessed on the concept that their problems are hormonal. That's another piece I see very recurrently, especially as a sexual medicine specialist. It's sometimes hard to accept that we have maybe relationship issues or anxiety or performance stuff. So a lot of men will say, no, 900 is not normal. It's not normal for me. And I'll be like, okay. I mean, and I've even gone as far as treating men in that situation, and they don't get better, and that helps them work through their process of accepting what may or may not be related to their sexual concerns. So yes, there's some definite areas of vagueness around what is an ideal testosterone level. You'll get a lot of opinions on that. To me, I think it's a safe assumption to say if we're in a range of 350 to 900 is where most men are, and matching that to symptoms, that's how we're going to be most accurate in determining what's the best level for a man. Because what I can also tell you from doing this for almost 20 years is that, there are plenty of men who we can increase their levels to 6, 8, 900, and they don't feel any different. They really don't feel any different. And so there's other men where you increase their testosterone levels from like 200 to 900, and they're radically transformed individuals, and they feel completely different, and their sexual function is radically altered. Depression resolves. I mean, it goes both ways. There are men who are going to have a dramatic response, and then there's other men who are going to be in that kind of quasi, is it really low? And then you increase it and they don't feel any different. And it's like, we need to start looking at depression or relationship or sleep or other stuff to really get that guy feeling his best.
Yeah. So the other thing that strikes me is how circular this is. So that even if somebody's showing up with lower testosterone, first of all, it's not necessarily, probably not an organic problem. It's probably a symptom of other kinds of things, but then it can also drive some of those symptoms. So I can see where this is complex.
It's very complex. And, I think it's fascinating. And I think what is ultimately the bottom line is to help men feel empowered in understanding that they do have actually more control over this area. Because when we're feeling depressed and we're struggling with erections and we don't want to have sex and we have, issues all around that are dealing with that, absolutely. Sometimes a testosterone product can be one of the spokes of a wheel. But what I think is the biggest takeaway is that testosterone therapy is usually one of a very global approach to help men feel better, both sexually and overall. And so that is sometimes men don't want to hear that, to be honest, sometimes, because it's like, well, no, just give me the thing. Just give me the thing. And I want to move on.
Just like with Viagra, right? Just give me the pill, give me the hormone. Let's just, get done with this.
Just give me the thing and let's move on. And sometimes it's a quick fix, sure. But most of the time, it's also a conversation of, hey, your diabetes is out of control, and that's why your testosterone is low. Or, hey, you haven't slept well in 20 years. We really need to tackle that. We need to get you treated for sleep apnea. And, sleep dysfunctions have a huge correlation to sexual dysfunction on the medical side also.
Yeah.
And so a lot of times it comes with, great, sure, let's get this diagnosed, let's get you treated. But the conversation usually doesn't end there, because it's like, hey, let's talk about romance. Let's talk about intimacy in your marriage. Let's talk about, are you aroused during sexual activity? Because testosterone therapy in and of itself sometimes significantly improves erectile or libido function just on its own. But usually it's also a conversation around what's going on in your relationship. Let's talk about, anxiety or stress at work, or these other things need to be ruled in. And so the men who do the best on testosterone, in my experience, are the men who are willing to look at it globally and have a more comprehensive conversation of like, A, why is it low? B, what are the best treatments for my age and my fertility status? And then C, how much of testosterone is really the key piece of what I'm complaining about? Because if it isn't, we got to keep going, right? We got to tackle depression. A lot of times I'm treating depression alongside that, and men are working with a sex therapist like you to kind of look at the relationship factors. And those are the guys who really do fantastic. When we get them 3-6 months into the process and they've got their medical areas treated and they've got their mental health areas treated and they're exercising more and sleeping more, these guys feel fantastic. I mean, it's like, that's where the rocket science comes in. It's like, hey, look at all these things and get to a place where your relationship's functioning well and your health is improved. That's where it's awesome. It's usually this whole thing of like, hey, let's take a global view and be proactive. But it's simple, like, here's some testosterone, have a nice life, see you in 6 months. It doesn't usually radically transform too much, know?
Right. Do you find if you've got a guy like you're talking about that's looking globally, they're tackling all these different things and using some sort of testosterone product, are they on that for the rest of their life, or is this the kind of thing that you generally see them wean off because they've resolved some of those underlying causes?
Well, it's a really good question. And that's another area where I think men sometimes lack proper education and consent before they start testosterone. And so most of the time, for example, if a man has a primary testicular failure or a pituitary dysfunction, meaning they have secondary hypogonadism or hypogonadal axis, blah, blah, blah. We have all these medical words. If they have those conditions, they are for sure on testosterone the rest of their life, because their testicular tissue or their endocrine systems to stimulate the testicular tissue are disabled. And so in those situations, there's absolutely no other way. I also have some gentlemen in my practice who are alcoholics who have struggled with substance abuse and have caused damage to their testicular tissue. Men who've undergone chemotherapy or radiation that causes permanent damage to the testicular tissue. So there's a lot of things that can happen where a man is in a circumstance where he's on testosterone the rest of his life. Absolutely. We don't have any other options. Now, for these younger men who have lower testosterone, who are maybe overweight, sedentary, meet medical guidelines, but are in a position where we know their testicular tissue can produce hormone, it's just not producing enough. Those are the best case scenarios where we would probably use an endogenous testosterone stimulating medication, not testosterone itself. And what we find is that if we help those men lose weight, exercise more, get their testosterone up with some treatments that help improve their own testosterone production, I think that that's the best case scenario where we will be able to get a man off treatment later on. So that's pretty reliable. Now,
is that not available to somebody who's 50 or something, or like older?
It is available to someone who's 50, and it's off label is the problem. So we don't have any FDA approved treatments for endogenous testosterone stimulation. We use a medication off label that works pretty well, but it's not FDA approved. And so the vast majority of men are going to be put on testosterone therapy. And if they are put on testosterone therapy as a young man, that's a bit of a conundrum, because that does potentially mean we're turning off their own testosterone production capacity themselves, right? So if they go off later, they usually feel even worse than they did when they went on to begin with, because we have turned off their own testicular production. So in those
doesn't come back online. It's not like you can get off the
It doesn't come back on.
Oh, wow.
Sometimes it does. I mean, it can take 3 to 6 months after a man. Usually the men who didn't need it to begin with are the ones who are going to jump back fine. if that
Yeah.
makes sense. So
Okay.
normally the men who had normal or suboptimal testosterone and totally are able to make it themselves, if you turn off their testicular production with testosterone and then take them off it, usually they can within, sometimes it's really quick. I mean, I've had men who have taken off, especially if they're not on for very long, and they can go back to normal pretty fast. If you have a man who's been on testosterone for years and years and years, and you take him off testosterone, he's almost always going to need some sort of medical therapy to try to stimulate that testicular production again,
Right. Okay.
especially if he is interested in conceiving after that. He may need urological procedures for sperm extraction and a bunch of other fertility type care in
Wow.
order to have a pregnancy. So those are complications that a lot of men are not educated on when they start maybe a quick treatment somewhere or with a provider who doesn't do it very often. Those are the things that men really need to be walked through of like, let's think this through. Are you prepared to be on this treatment forever? And if you're not, let's talk about what that looks like. Because the other consideration is that insurance coverage is a really big topic. Testosterone therapies that are FDA approved, there's like 19 or 21 or something. There's a lot of them. They're typically run $800 to $1,000 a month. And so if a man wants insurance coverage, he needs to meet these medical criteria. And then we also have to continue as medical providers provide that evidence to their insurance that continues to validate that treatment. Because if they're looking for lifelong treatment, that's another reason why they really better have been diagnosed properly in order to justify that. And a lot of the clinics in our area and across the country are cash-based clinics that don't meet those medical criteria and don't bill insurance. And so they're, usually $3,000 to $5,000 to get all of this treatment done, but it's not being covered under the insurance because it never met medical criteria.
Right. So it's like this optional. I mean,
Yeah.
Tell me you want it and I'll give it to you kind of thing.
Exactly. And millions of men in our area and across the country are on treatments in that fashion. And, to be fair, the reason why those types of clinics have really escalated in our country is because historically and even currently, physicians have done a very poor job of really addressing hypogonadism or sexual dysfunction, which is what prompts a lot of men to look for testosterone treatment.
Right.
We've done a really terrible job. Urology, primary care, endocrinology, across the board, we have not done a good service to men in our country. And so a lot of these pop-up clinics have really flourished because they are more willing to give men treatment that their regular provider perhaps was not willing to. So I understand where that frustration comes from men, because if they're in their general primary care doctor's office or a urologist's office and that provider is like, I don't care about you having low libido. Like, I'm not interested in working that up for you or whatever, here's some Viagra, have a nice day. I mean, the average medical visit is 2 to 7 minutes, and you really can't address these types of complex issues in 2 to 7 minutes, right? So that's where a lot of it has kind of flourished. So, I mean, the good news is that I like that men have more options to kind of seek for treatment. The bad news is that, unfortunately, if they land in an illegitimate clinic environment, they're not getting good care there either, right?
Right.
So it definitely is complicated. And I think because we have the irony I've observed over the past 15 years of doing this is that because we've had this huge flourish of millions of men in these walk-in clinics, a lot of urologists and men specialists have gone, hey, whoa, why are we not serving this population appropriately? And now we have pushed our patients into these environments that are not good care. We need to ramp up. We need to do a better job. And so there's been a big push in like hospital systems and urology and men's clinic facilities to bring back in, that combined, hey, we need to help men better in this area. And we want to do it under an evidence-based medical guideline approach, but we may be better spend more time getting better at this ourselves so that men don't feel like their only options are, a mall stop and shop kind of situation,
Right. Hey, this is Jess. I'm just taking a quick break, and I want to make sure you know about the guide I wrote about how to talk to your partner about sexual concerns. This comes up a lot in my practice. People have struggles, and it takes them so long to bring it up with their partner. They're afraid that conversation is going to go badly. Their partner's going to be upset. The partner's going to be defensive, or they just don't know how to talk about sex and sexual problems. Common problem. So I wrote this guide that really helps you address this. It helps you prepare for the conversation, how to introduce the conversation, and then tips about how to actually get through the conversation so that you can change things with your partner as a team. If you are interested in this guide, you can find it at bettersexpodcast.com/guide. Again, bettersexpodcast.com/guide. Happy to send it to you. So if men are starting to take testosterone at 40, 50, 60, something like that, does that shut off their testosterone production? Are they on it for the rest of their lives?
Yeah, they are. That's right. Okay. Yep, that's correct. Now, there's men, prostate disorders and prostate cancer is really quite common in men as they age. And so there's also another area of quite a bit of controversy around testosterone therapy use and prostate cancer. And so historically, if a man has prostate cancer, which many men do, they will be taken off testosterone therapy. So there are also a huge area of controversy around testosterone therapy and heart disease risk. And men, as they age, as women, increase having heart disease and heart disease episodes as they age. And so there's medical conditions, is what I'm trying to say, where we may take a man off of testosterone therapy because of another condition that develops as he gets older. But that testicular function's not coming back.
Right. So then they're just going to live in a low T state, right?
Right.
Like because the risks of supplementation are too high, but
right. And there are some men who are frankly okay with that. I mean, there are men who perhaps are not sexually active in their marriages or are widowed or not married or aren't interested in sexual activity. And, bone density is something that increases as we age in risk as well. And so maybe they already have osteoporosis. And, it's a pros and cons approach. We have to look at every age and at every stage of like, what are the benefits of hormone therapy? What are the disadvantages? And what is that layout for an individual man looking for treatment? And in terms of, libido or erectile function or ejaculation function, we know that there are a lot of other treatments as well, especially if those symptoms are not coming from a testosterone deficiency disease. And, I can also tell you statistically a vast swath of men, I can't remember the number, it's like 70% or something, who are starting on testosterone eventually discontinue within like 1 to 3 years. Wow. And the reason why they do that is that it doesn't do what they think it's going to do. It's like, wow, well, I've been on this and I don't really feel that different. And I don't really want to still do this injection or this pellet or this gel for the rest of my life. So they'll stop taking it. And then their previous state that they used to think was a problem suddenly becomes, oh, actually, this isn't really a problem, is often how it goes, frankly. But yeah.
But I think you're saying those 70% of men are going to have damaged their own ability to produce their own testosterone in the course of those few years.
That's right, potentially. And so that's a pretty big deal, right? If you are in a relationship where you want to have a baby and you realize this testosterone that you thought was fine or benign actually has impaired your ability to produce sperm to create a pregnancy, that sucks. That's very frustrating. And a lot of men will feel very betrayed or like, why didn't anyone tell me this? So that is a big deal. And, there are men who are younger who are like, no, I don't want to have a baby. I'm good. Like that's not an issue for me. And those are men who, if they're properly informed and consent to that consequence of testosterone, then it's a non-issue. It's the men who were not properly educated that is a consequence. Now, also, just to give you kind of full context, there are HCGs, an injection that a lot of clinics will give men in addition to testosterone, which is believed to potentially offset some of that infertility consequence of testosterone, but it hasn't been definitively proven, and it's not within medical guidelines to use those concurrently and tell a patient that they will maintain fertility. It's certainly possible that it will help. It's been used for quite a while. We do have research on it. And so that's the in-between where some men will be, is that they'll say, well, I'm on testosterone, but I'm also taking this other injection that my doctor said will prevent me from being infertile. And it's like, yeah, that might help. I think it's a stretch to say for sure. And there is no medical provider within guidelines that practices that way with a definitive guarantee to a patient that their fertility will be maintained. There's always a risk of losing fertility capacity if you're on testosterone therapy. So it just depends on how much that matters to a man. And sometimes it changes. I mean, I have a gentleman right now who we went through all this and he fully consented and he didn't want to have babies, and then life changes and 5 years later he has a partner and he wants to have a baby, and now he's doing pretty extensive fertility treatment in order to extract extract, he has to go off this and on
Right.
that and
Right.
and we have to surgically extract sperm because he consented and agreed and then later changed his mind. So
Right.
that
Right.
happens too, where then you're kind of in a big conundrum where you're like, well, now I have
Yeah.
to go through all this to kind of backtrack on that. And, so, but that's fine. We have options for all these things. And that's also important for men to know. Yes, we can get ourselves into some conundrums with testosterone therapy, but we have really great clinicians and different specialties who can work through any of those situations. It just
Right.
sometimes takes longer and requires more treatment than men were expecting.
Right. But and if I understand you, fertility is not the only. I mean, somebody could do testosterone for a few years, still don't want a baby, get off of it, and then they're going to be at a lower level of testosterone production. They will have damaged, right? Like this, so they might have lethargy or sexual functioning issues, or
That's right. Yeah, and oftentimes
osteoporosis or whatever, right? Like they will have undercut their own system.
That's right. That's correct. Now, usually within 6 months, that will kick back up. However, in that situation, during that time, a lot of men will struggle with significant depression or, not feeling well. And so we have treatments that can ease that transition that make it easier for sure.
Okay.
Most men don't seek that kind of treatment. Most men will stop testosterone on their own, feel a little crappy, eventually feel fine, and then life moves on. Right. So the amount of men who are like, who have gone through a foray of testosterone is going to like change my world. And then like, oh, actually it didn't. And then they get off it and move on. That happens all the time,
So they can recover it. They're just going to go through a dip generally.
That's right. Yeah, usually especially if they weren't ever needed to have it to begin with, right? If their testosterone levels were normal and they were put on testosterone and they don't feel better and they go off, those men are going to resurge better. If you have a man who genuinely was hypogonadal to begin with, he's not going to recover that testicular function when he goes off because he never had that to begin with, right? So that's where it gets, nuanced and complicated. And there are medical specialties called andrology that this is what they do, and so it's usually a combination of endocrinology, urology, sexual medicine, and andrology that are resources for men to kind of walk through their individual circumstance.
Okay.
Yeah.
And then of the various, you said there's like 21 products or something like that. What are the sort of risks or reasons to use? I mean, I'm thinking about injections versus, what are the various types and which seem to be the most risky or the most effective, or what do you want to say about that?
I think we're still learning a lot about that. What I can say, generally speaking, is that the risk of clotting seems to be quite a bit higher with injections, especially with, for example, there's a high dose product that I don't think is in use very often, but there's a high dose product where we do an injection in the office, and it's something that you are given at a less frequent rate. So instead of injecting every week or two, you can have this one large injection that counts for several weeks. After that injection, we are medically required to observe that man in the lobby for 30 minutes to make sure he doesn't have a clot that goes to his lungs.
Wow.
Yeah. So, I mean, I think that's, and a lot of men are surprised to hear that because there's this notion that hormone therapy is just natural and like harmless and this anti-aging miracle where why aren't we all on it? And the reality is that when you really look at the research, the risk of a clot is very low. It's very low. And in this particular product, it's a micro clot. Cough is the most common symptom, but still it suggests and emphasizes that clotting and heart disease risk is something we've debated quite fiercely. And we had some research about 4 or 5 years ago that was a very large study that was, I think, in the end determined to be very poorly done, but caused a lot of panic in our medical areas around, does this cause heart disease and does it cause heart attacks and does it lead to clotting and stroke? So we're still walking that out. We never have definitive answers in medicine, but that's one of the things that is important. If a man has heart disease and he's under the care of a cardiologist, it's most conservative to have that treatment cleared by a cardiologist. That doesn't happen very often, but that's the most conservative route to go of like, if you have a heart condition that increases your risk of having a cardiovascular event, that should be part of the conversation when we start testosterone. So we're looking at, does it increase the risk of prostate cancer? We're still in controversy about that. Does it increase heart disease? However, the flip side is that we also have quite a large body of evidence that suggests appropriately treating men who have hypogonadism will prevent the development of diabetes and may prevent the development of heart disease. So it gets really confusing. And And especially for the average person, it's like, wait a minute, what are you docs saying? Like, is it going to hurt me or is it going to help me?
Right. If only there was a clear answer. And what about, are there topical? I mean, I guess I've got this idea that there's some forms of testosterone treatment that can be risky to your partner or to your kids, or that somehow spreading.
That's a great question. So the most common, and the way that, just to clarify here, the way that men will usually make a product selection, because we have gels and sprays and things that are transdermal and that goes through the skin. We have injections, several forms of injections. We just had an auto injector product come out on the market. And then we have pellets. We have hormone pellets. And so there's really three. And then there's also some buccal things that nobody ever uses, little pills you put in your gut. There's a whole lot of products. And some are, the way a man will choose a product is frankly based on what his insurance will cover most of the time. And that's almost always going to be a transdermal gel. Okay. A generic transdermal gel. So that's a product that looks like, I don't know if you can see it, but there's a little tube, or it's a pump. And a pump or a tube are the most common forms that insurances will pay for.
Like a gel or lotion or whatever. Yeah.
Yeah, like a gel or a lotion. There's another one where you put it under your arm. It's like a little deodorant thing. So there's a long list of products, and those tend to be, we think those are probably safer for clotting risk, but they do also have that potential for a man to transmit that to a pet, a child, a partner if he doesn't apply it properly. And to apply it properly is super easy. It is super easy to mitigate that. You apply it, you wash your hands, you let it air dry. It's not a big deal. But it is important for men to know, if you're using a product of that kind, you just want to make sure you do these small steps, because if you apply it and then rub up against a pet or, have a child on your lap and get it on their skin, it can transmit and cause disruption for their endocrine system if that's a regular occurrence. I mean, here and there a little bit, it's not going to hurt anything. It's like if there was some consistent exposure. So, I mean, that is real for the gels, but it's easy to be offset. So if you're looking at an injection that's going to eliminate that risk, there's no transference risk.
Yeah.
And then the hormone pellets, I think, are fantastic. There's one product that's FDA approved for men, and it is something that we surgically sounds like a strong word. I mean, it's a procedure where we insert it in the office. It doesn't take very long. We just make a small incision in the buttock area usually, and then we insert these 10 pellets that kind of look like Tic Tacs. I'm going to show you one of these too. Yeah, little Tic Tacs. And so what's cool about that product is that it is a slow release and then a slow decrease in serum production of that hormone. So when we're looking at injections, there's usually much more of a up and down. And so men
like
feel differently, more like a blast, and then it goes down. So, those are the differences in terms of how a man will feel, what his insurance will cover, and how well he tolerates it, and who else. And a lot of times it's just preference. Some guys will feel better on an injection, frankly. Other guys love the pellets because that's something 3 or 4 times a year we do this insertion, and then that's it, and they don't have to think about it. And so if a guy's really bad at remembering to do stuff, if he forgets the testosterone gel all the time and he's not using it, then that would be another reason why we might switch to a different product if his insurance will cover it. But to be honest, insurances have gotten really finicky because these products are expensive and a lot of men are on them who shouldn't be. And so insurances are trying to weed those out and say, hey, you don't meet criteria. We don't want to pay $1,000 a month for this treatment. We don't think you need. So that can be frustrating if a man genuinely needs this treatment and their insurance is refusing to pay for it. We spend a lot of our time in our office dealing with that, and it's obnoxious. So that's hard too, right? There's obviously no perfect system here, but usually we'll kind of talk men through what the options are. Maybe they have a preference for one reason or the other. We try to get that covered. If it's not, we'll try something else. Usually we'll find it takes us a little while to find the right therapy. And then if a guy feels good on it and everything seems to be working, we're off and running, and we don't usually change it much after that.
Right. Yeah. So is it a whole other interview someday to talk about testosterone in women? And what level should be?
Is.
Okay, so let's just leave it.
Well, we can do some. I mean, how much time do you have? We can do some overview on that.
Well, it could take maybe 5 minutes or something. If that's enough to give an overview, we'll do this as like a teaser for our next conversation. Then
I love that. All right, let's do a teaser. So here's some interesting kind of just beginning statements on testosterone in women. So in the sense that men make testosterone in their testicles, women make, as I said earlier, in their ovaries and their adrenal glands. So as women go through menopause, which is a more distinct reproductive change than men have, right? Men, in theory, still maintain testicular function as they age. Women have gonadal disruption or failure, or it's not failure. It's a
It's doing
natural
what
stage
it's
of
supposed
aging.
to do. Yeah.
It's
Yeah.
doing what
You're
it's
right.
supposed to do. Yeah. But I mean, from the hormone production piece, we consider that a completion of that
Yes.
cycle, right? So that happens around 51, 52 for women. So when women go through menopause, testosterone levels for some women decline. We still produce it through the adrenal glands. So testosterone, the large summary point here, is appropriate for some women who have low libido or sexual dysfunction after the age of menopause. Really not before. And the other key takeaway for testosterone in women is that, similar to men, there's a lot of myths about testosterone being the anti-aging sexual function cure. It's a hormone problem for sure. I just need a hormone that'll fix it. There's a lot of misconceptions in women in that area too. And what it's really important to understand is that it causes fetal harm in women who are of reproductive age. So
Right.
if a woman is taking testosterone before the age of menopause and she has conceives, that can cause harm to the baby. That's really important for women to know. And a lot of women don't know that.
Yeah.
So first of all, testosterone has not been shown to be significantly effective for women for really anything at all when they're younger. It's only after the age of menopause that we have found testosterone to potentially be one treatment we have to offer orgasmic issues, other things related to sexual function.
Yeah.
So the application for women is much smaller, I would say, than it is for men. And it is not FDA approved for women, which means that any product we use is off-label, not covered by insurance, and that leads to kind of a little bit of conundrums in terms of what type of product and what, because men have these like 18, 20, whatever long list of options. Women have 0 options, and so clinicians who specialize in menopause or sexual function have specific things that we do and talk patients through, but it's not ideal because we don't
Right.
have an FDA approved product. So
Okay.
we do have really good global consensus guidelines on the use of testosterone in women. We just had that released, a huge medical guideline compilation last year, so 2019. So we have a lot of research in testosterone in women, but it is also a quite complicated topic because similar to men who kind of have this hope that testosterone therapy is going to fix all of their things, menopause is a complicated time for a lot of women, and that's also libido issues, sexual function issues, depression, sleep, mood, low self-care, not exercising, all this compilation of I don't feel good. And it's like, well, we can talk about testosterone for sure, but similar with men, what else is that symptom actually representing, right?
Right.
Yeah. So there's a 2-minute snippet. Can cause fetal harm, really isn't helpful until after the age of menopause.
Okay. So what would you say, how do people find help? I mean, obviously, if they are in Kirkland or in the Seattle area, they can go to you. So I do want you to, let people know where they can find you too. But also how, let's not go into a mall walk-in clinic. How do people find appropriate diagnosis and care?
Well, and there might be an appropriate clinician in a wall-walk-in clinic. I don't want to completely, belabor that. Maybe I'm misrepresenting that. So it's less of the facility; it's more of the qualified clinician. So anyone who is a urologist, an endocrinologist, a sexual medicine specialist, or an andrologist are the clinicians I recommend. And so that means there are people who follow medical guidelines, who have experience in this treatment. And sometimes there's a primary care doctor who is really well educated and spends a lot of time in this area, or an internal medicine doctor who does this. Great. Maybe there's someone who's fantastic in a strip mall, who has that education. So, asking these questions, and having a list of, knowledgeable questions to come in is a really good place to start. If you walk into a facility and within 2 minutes they're giving you a testosterone prescription, that's a red flag. It's like if somebody is not taking time to do another red flag, if they're basing your treatment based on one blood test only, especially if it's not a blood test that's specifically ordered for 8 to 10 in the morning. If it's just kind of a flippant, like, yep, we're going to get your blood test done. Here it is. It's done in the office. I'm going to give you $3,000 worth of treatment, like right now. It's a little red flaggy, right?
Right.
And so if somebody has the experience and the knowledge that's what you're looking for. And, there's going to be some quick stop clinics that are also reputable. It's not that fast food model is necessarily ill fit for every man, but it depends entirely on the clinician. It depends entirely on what that algorithm is. And typically, if it's a cash-based clinic, that means they're working outside of insurance guidelines. And that means they're not necessarily going to meet medical criteria. Now, there's some arguments that our medical criteria are missing some of these nuances around appropriate diagnosis. We can certainly have that conversation. But generally speaking, if it's a quick visit anywhere, it's probably not going to be the best care. And if it's cash, it's important just to recognize that clinic is working outside a medical model. It's in the sense that it's not necessarily feeling responsibility towards adhering to medical guideline treatment.
Right. Okay. And where can people find more about you?
Well, my website's drserena.com. Pretty easy. So I work with a group of urologists who are also fantastic. So I recommend them also. We're one of the largest urology and interdisciplinary groups on the east side. So we're pretty easy to find. Washington Urology Associates or drserena.com.
Great. Well, thank you so much for being with me.
You're welcome. This is really fun. Anytime. Thanks for having me.
Sure.
You've been listening to Better Sex. Please visit our website, bettersexpodcast.com, for show notes and additional episodes.
And that's a wrap for today. I really hope you enjoyed the episode. If you are enjoying the podcast, if some of this material resonates with you and you would like to make a difference and make sure that this keeps coming out in the world once a week, ongoing, there are a couple things you could do to show your appreciation. The first would be to go to iTunes and rate and review the show. That really helps us be found by new listeners when you review the show on iTunes. You can find a link at bettersexpodcast.com/iTunes. The other thing I want to invite you to consider is becoming a Patreon. For a small monthly pledge, you get some benefits. So for $2 a month, you get advance access to every single episode. For $5 a month, you get a chapter of my upcoming new book. And for $10 a month, I host quarterly get-to-know-you and question-and-answer chats over the web, and you get invited to that. I would love to have your membership in that, become part of the Better Sex family. You can find a link at bettersexpodcast.com/Patreon, which is Patreon. Again, thanks for listening. I'm glad you're here. Feel free to comment, ask questions, get in touch. I'd love to hear from listeners. Thanks.